Hey, everybody. Welcome to the last of our home edition series. And I hope you've enjoyed the other speakers. Today, I'm really happy to be winding up with one of our friends and colleagues who has been so great to the foundation. Before I introduce him, however, I just want to do some quick housekeeping. And the first part of that would be to thank our sponsors, Turner's Tribe and Robert and the Eva Worthy family have been our gold sponsors for this series. And then our silver sponsors are AMO Pharma, Autism BrainNet, Barrios and Associates, and Neuron Pharmaceuticals. We also had another silver sponsor, excuse me, who decided to remain anonymous. In previous sessions, you may have seen the Autism BrainNet video. I would really like to encourage you, if you have the app, and I'll remind you how to do that in a second, that you go onto the app to that sponsor, and there's a little button there, and if you press it, you can fill a form out and get some free swag sent to your house. It's a really nice package, so I hope that you'll join in doing that. So again, on the app, go to the sponsor page, Autism BrainNet, and click the green button. You also may have noticed, if you signed on a little bit early, we now have a conference t-shirt. I'm really excited about that too. It's got a double benefit in that it supports the foundation, but the vendor is Brooke Jones of Turner's Tribe. She's producing the t-shirt, so you benefit one of our family members and the foundation if you choose to buy one. You can get that on the app directly as well, or you can go to our store, and we'll have a link to that in this month's newsletter as well. They are limited time only to the end of the month, so get them while they're hot. If you haven't downloaded the app, you can do that through either Apple or Google Play. Just go on, type in PMSF. The access code is 20PMSF20. And I hope you'll do that so you can meet some of the other people here. And again, look at our sponsors, and it's where you'll do your evaluation, which I'll explain at the end of the session today. So today's session is entitled Sleep, Epilepsy, and Quality of Life in Phelan McDermid Syndrome. And I'm really excited to introduce Dr. Jimmy Holder. He's a child neurologist at Baylor College of Medicine and Texas Children's. He graduated from Johns Hopkins and then went on to get an MD and PhD in human genetics at the University of Texas Southwestern, and then went to California to do a fellowship in neurogenetics, and then back to Texas, where he is now not only doing where he completed his residency, but he directs a shankopathy clinic that sees over 40 of our kids. So he really is one of the experts in Phelan McDermid syndrome in many areas, not just seizures. He continues to investigate everything from quality of life to neurobiological and molecular structures of PMS. And we're really grateful for his kindness in appearing today and for his continued research and commitment. So without any further ado, I'd like to get started with Jimmy. There is a QA function, by the way, at either the top or bottom of your screen. You can ask your questions, and we'll save a little time for Q&A at the end, and I'll be moderating those. So thank you very much, and here's Dr.
Okay, terrific. Thank you so much, Ronnie, for that kind introduction. And I want to thank all of the attendees for tuning in to listen to me today, and as well as certainly the foundation for all of their support and for producing this great series. I think it's going to be really helpful. I think it is really helpful for all of the families. So, as Ronnie mentioned, I'm going to talk a lot about epilepsy today. And for those of you that have heard me speak before, some of the slides will be similar, but it just really gets us all kind of grounded to the same point and understanding seizures and epilepsy in general and in Phelan McDermid syndrome. And then I'll talk about, relatively briefly, some new work that we've done with regards to impact of Phelan McDermid syndrome on sleep and on health-related quality of life. So our objectives today are to define what are seizures, what is epilepsy, and I'll show you some examples of different types of seizures, define different types of seizures, things to be on the lookout for in your own children. I'll describe different types of treatments for epilepsy, both pharmacologic and non-pharmacologic, which both can be quite important for individuals with epilepsy. I'll describe some life-threatening complications associated with seizures. We'll review kind of the older literature in seizures and epilepsy and Phelan McDermid syndrome. And then I'll describe some work that we did, we published a few years ago now on our experience at Texas Children's Hospital with regard to seizures and epilepsy in Phelan McDermid syndrome. I'll talk about a manuscript that was published a couple of years ago now on the use of long-term EEG in children with Phelan McDermid syndrome. And then I'll shift gears and describe the impact of Phelan McDermid syndrome on health-related quality of life and tell you a bit about what is health-related quality of life. And then finally end up by discussing the impact of Phelan McDermid syndrome on sleep. So first, we'll define seizures and epilepsy. So a seizure is a transient disruption of brain function due to abnormal or excessive electrical discharges in brain cells. And then epilepsy, it has a really, it's, sometimes thought of as kind of mysterious how you define epilepsy, but it's actually quite simple. It's a clinical diagnosis. And basically, the diagnosis is made when there's more than one unprovoked seizure. So one key is that word unprovoked. A provoked seizure would be something like if someone has a strike to the head, say a baseball strikes them in the head and they have a seizure immediately after and they never have a seizure again, that would be considered an unprovoked seizure. Sorry, a provoked seizure. So an unprovoked seizure is basically a seizure that happens without any preceding event that can likely explain why a seizure occurred. Then there's EEG, which is an electroencephalography or a brainwave test. Again, this is not a method for diagnosing epilepsy usually, but for defining what type of epilepsy might be present or the efficacy of a drug that's being used. Sometimes it's used for those things. And then magnetic resonance imaging or MRI. This is an imaging modality that we very frequently use in children with epilepsy or who have had a seizure to try to determine if there's a structural cause for their seizure. So what do we do when a child has a first unprovoked seizure or has a diagnosis of epilepsy? There are usually two key diagnostic tests. The first is an outpatient EEG. This is an EEG where that lasts anywhere from 30 to 45 minutes. A child just comes into the EEG lab. You see here on the right a child being hooked up to an EEG. You have these electrodes, these little wires that are just taped onto the surface of the scalp. And then we record electrical activity for, like I said, about 30 or 45 minutes. Often we ask parents to sleep deprive their child the night before. And the reason for that is we like to record EEG both in children that are awake as well as are asleep. Sometimes seizures or abnormal EEG findings are more prevalent when a child is asleep than awake, which is why we often ask parents to do that. And then again, we want to determine whether there's a structural reason in the brain that caused a child to have a seizure. And we do that through an outpatient MRI of the brain. The things that we're looking for are things like tumors or evidence of a stroke, relatively uncommon things in children, but things that we need to rule out. And once we do, then we can say, well, this child has something called idiopathic epilepsy. That means epilepsy for an unknown reason. And then we can go on to do other things, other tests, such as genetic testing if there's not a clear cause of the seizures in the child. And then finally, after these tests, if a child is clinically diagnosed with epilepsy, we often then go on to medications. And I'll talk about medications in a minute. So what are the different types of seizures that one can have? There's the type of seizure that everyone thinks of when they think of seizures or think of epilepsy, which are actually down here at the bottom, these generalized tonic-clonic seizures. These are the grand mal big seizures that, again, are kind of in everyone's mind when they think of a seizure. But there are a lot of different other types of seizures that are much more subtle. And the first one I'll talk about are absence seizures. These are brief, often lasting just a few seconds, staring spells that can be associated with or without stereotypies. Stereotypies are movements that are not the large movements that you see in grand mal seizures, but more look like potentially purposeful movements, things like lip smacking or perhaps picking at clothes, but that occur during a seizure and are the mild motor manifestation of that seizure. And I'll show you an example of this in just a minute. You can have a different type of staring spell, a longer staring spell lasting a few minutes, that's associated with a complex partial seizure. This is a type of seizure that begins in one area of the brain, one focus within the brain, which is where the partial comes from, but then can actually generalize to involve the entire brain from that initial epileptiform focus. Again, these can be staring spells, but there can be some motor manifestations as well with complex partial seizures, including things like eye deviation, which is where the eyes are basically fixed to one side or the other. And these, again, can evolve into generalized seizures. A third type of seizure are atonic seizures or drop attacks. These are very brief, but can be quite devastating seizures. They're associated with sudden loss of tone. And the sudden loss of tone can be actually quite mild, just involving a head nod, all the way to complete loss of head and truncal tone, as well as extremity tone, leading to a child or an individual falling straight down, which of course can be very dangerous depending on the situation that the individual is in. Next are tonic seizures. These are usually generalized seizures, although they can be partial onset seizures with a dramatic increase in tone without clonic movements, without these rhythmic movements. And this increase in tone is manifested as a sudden stiffening of the body. Again, the generalized tonic-clonic seizures, these are the grand mal seizures associated also with increased tone, but then usually with rhythmic movements. Now, these can, again, last potentially a few seconds to a minute, or can be very prolonged, depending on the situation. And then finally, there are myoclonic seizures. These are sudden jerking movements. Usually these are not rhythmic. These don't look like the generalized tonic-clonic seizures, and I'll show you an example of myoclonic seizures in a minute. But these are very, very brief and just sudden jerks that can occur. If any of you have had sort of jerking movements when you fall asleep, which is completely normal, that's sort of what they can look like. So here's an example of an absence seizure. So first, this child is just hyperventilating. So she's not having a seizure yet. She's doing this voluntarily. She's breathing very fast. And then when you see her stop here and just start staring, you can kind of see some mouth movements. You see her picking at her clothes. This is the seizure itself. So this is very subtle. If you didn't know what you were looking for, you might not think this is a seizure. And as you'll see in a minute, it really just lasts a few seconds. And as soon as she lifts her head up, the seizure is over. And there the seizure is over. The children who can communicate well, usually are completely unaware that a seizure has occurred. And again, you saw that this is not associated with these big rhythmic movements. This is really a pretty subtle event. So next, I'm going to show you a complex partial seizure. In this case, this will not be a staring episode, but rather one with some complex leg movements. So here she's watching TV or something, and then seizure starts right here. And you can see the sort of bicycling movements of her lower extremities. And if you watch her head and eyes, you can see that this child has deviation of the eyes and the head over to the left, over to her left. And so seizure is ongoing here. You see it's lasting a few seconds. This one's a relatively short one. Kind of that big breath at the end of the seizure. And here she's going to wake up and be back to normal. So again, not the big rhythmic movements necessarily that we typically associate with seizures, but a slightly different motor manifestation. Okay, so this child is going to have an example of an atonic seizure. So you see here the child's just playing, they're playing with a ball, doing perfectly fine. And in just a second, you're going to see her suddenly lose tone in her head and her upper body. Right there. So sudden loss of tone. And then you see her head pop right back up. So the seizure's over within 1 or 2 seconds. Very, very brief. But obviously, she was safe in a bed, no concern for any sort of injury. But in a child or an adult with atonic seizures who's walking around, walking up or down stairs, there could be a definite concern for injury. And then here I'm going to show you an example of some myoclonic seizures. So this individual is just lying in bed, and suddenly you see a little bit of movement of upper extremities, of lower extremities, goes away within a second or so. And then another group of seizures here with bilateral upper extremity movement. So again, these are not the big rhythmic movements of tonic-clonic seizures, but these are they are motor seizures. In this case, with myoclonic seizures, often an individual is completely aware that they're happening. They're very, very brief, but just these uncontrollable motor movements. All right, so what are the treatments for seizures or for epilepsy? So there are a number of different pharmacologic medications that are available for seizures. The most common class of pharmacologic agents are the voltage-gated sodium channel inhibitors. And these include quite a large number. I think I have most of them on here, but I may have missed one or two. Some of the older ones are things like phenytoin, fosphenytoin. These are not used so much these days for maintenance of seizure control, but we use them, especially fosphenytoin, in cases where an individual or a child is admitted to a hospital with a prolonged seizure. Carbamazepine also a bit of an older medication, but oxcarbazepine or trileptal is one that we actually use quite frequently these days for control of seizures. And again, these are, I think I forgot to mention this, these are particularly efficacious for those partial onset seizures, those seizures that begin just in one part of the brain and can just stay in that one part of the brain or can generalize to involve the entire brain. And then there are some newer medications. Carbazepine is a newer medicine based on the structure of oxcarbazepine that is used sometimes for partial onset seizures. Rufinamide is a bit of a special medication for seizures used primarily for things like Lennox-Gastaut syndrome. Lacosamide and lamotrigine are also medications with voltage-gated sodium channel inhibition that are used for partial onset seizures, although lamotrigine is also used for other types of seizures. And then there are a really quite older class of medications called the benzodiazepines. Um, these are efficacious both for partial onset as well as for generalized seizures. Some of the older medicines that are available are things like diazepam, midazolam, and clonazepam. I personally, those three medications typically don't use for maintenance of seizure control. A couple of reasons for that. One is that they can have one of the big side effects of the benzodiazepines is significant sleepiness, especially with initiation, but they can continue with continued use of these medicines. The second is because of tolerance that can develop with these medications, such that the individual has to take more and more of the medicine for efficacy, and that just results in increased side effects. A fourth kind of special benzodiazepine is clobazam. In the United States, that would be, you would know it as Onfi. This has a slightly different chemical structure, which actually makes it less prone to tolerance and less prone to those common side effects of benzodiazepines, such as sleepiness. And we actually use that quite a bit for a number of genetic epilepsies. And I use it for at least a few children with Phelan McDermid syndrome. Levetiracetam is kind of a special class of medicine. So it's also efficacious both for partial onset, generalized seizures, as well as those myoclonic seizures. It's somewhat special. It works differently than basically any other class of seizure medicines. And then it has a different side effect profile, which is good. It does not, in general, cause the sort of sleepiness that's associated with some of the other seizure medications. However, there can be significant behavioral side effects associated with levetiracetam and its cousin, brivaracetam. And this can be manifest in terms of aggressive behavior, relatively rare cases, outright psychosis in individuals that take these medicines. Again, these are very rare side effects. Well, the psychosis is a very rare side effect. Some degree of agitation is actually not too uncommon with this medicine. There are things that we can do to try to improve that. There's actually a vitamin that there is some evidence improves the agitation that can be associated with this. But the nice thing about this medicine is that it does not interact with other medications very much. And it's something that there's really, as best we know, there's not a significant toxicity with any dose of this medicine. So we can go up to a relatively high dose for this medicine. There's a relatively new class of medicines now called the glutamate receptor antagonist. And there's really basically only one that's clinically used, which is called perampanel. Again, this medicine works slightly differently than, well, it works differently than the other classes of medicines I mentioned before. It can be used for both partial onset as well as for generalized seizures. It also tends to not have so much of the drowsiness side effects that are associated with voltage-gated sodium channels, as well as the benzodiazepines. This one does sometimes, in some individuals, have some effect on behavior, which can limit its usefulness. But otherwise, it's quite a good medication that I have used in the past. Another older class of medicines, but that are really quite efficacious for some individuals, and I use quite a bit, are the medicines characterized by topiramate and zonisamide. These are what we call wide spectrum anti-epileptics or broad spectrum anti-epileptics. And because they can be efficacious for those partial onset seizures, as well as myoclonic and generalized seizures. These two medicines also have some of the side effects of sleepiness, especially with initiation of the medicine, though that tends to improve with time. Some rare side effects include things like kidney stones in about 1% of individuals that take these, although that usually occurs in individuals that have a known history of kidney stones or have a strong family history. And then another side effect that is something to be very cognizant about when an individual takes these is hypohidrosis or anhidrosis. That's decreased or completely absent sweating, even in the face of high temperatures. So certainly in a place like Houston, we always have to be wary of that and make sure parents know about that and try, to ensure that their children do not become overheated. And then quite an older medicine, but still one of the best medicines in terms of how well it works for seizures, is valproic acid. Some of you might know it as Depakote. Again, it's a broad spectrum seizure medicine that works on partial onset, myoclonic, and generalized seizures. This one works really well. It's very, very good for controlling all types of seizures. It's really limited, somewhat limited by its side effect profile. So pretty much everyone that takes this medicine will end up with some sort of side effect. Some of them are relatively mild, things like increased hair growth. Some people put on a bit more weight when they take this medicine, things that would not necessarily limit its use. But then there can be problems with blood production, so we have to monitor that. There can be issues with liver function, with pancreatic function. We have to monitor those as well. So again, very, very efficacious drug, just with quite a few potential side effects. And then one that, of course, a lot of people are very excited about is cannabidiols, and the only pharmacologic formulation for cannabidiols is Epidiolex. Currently, I think this is still true that it's only approved for Lennox-Gastaut syndrome and for Dravet syndrome. I know there is a lot of work going on to develop new indications for this medication, which will certainly come about in the coming years. It's one that I have a bit of experience with, certainly talked to our epileptologist at Texas Children's Hospital. It definitely works for seizures. It's not the holy grail. There are some individuals that respond beautifully to this, completely stop their seizures. There's some individuals that don't respond to this, has very little effect on the frequency of their seizures. And then, there are side effects associated with this. In particular, GI symptoms can be a big problem with this medicine. So, definitely a new tool to use in the fight against epilepsy, but not the holy grail. Okay, so there are both, I mentioned at the beginning, there are both pharmacologic and non-pharmacologic treatments. So I'll go a bit into some of the non-pharmacologic treatments. One is something called vagus nerve stimulation. In vagus nerve stimulation, basically an electric lead is placed on a nerve within the neck called the vagus nerve. This is a nerve that emanates from the brainstem and goes down into the gut. So electrical leads are placed on this nerve, and then the wire goes to the stimulator, which is placed in the chest. The stimulator fires periodically throughout the day, and a neurologist or epileptologist can change the settings on the vagus nerve stimulator in terms of how often it fires and how much it fires. Um, the newer vagus nerve stimulators also can fire in response to the presence of a seizure. The presence of a seizure is determined by things like changes in heart rate that are usually associated with seizures. They can also be activated by a parent or a guardian. That when a child or when an individual is having a seizure, a magnet's swiped over the chest, and then the stimulator fires to the vagus nerve. We really still don't know exactly how this works. There's some thought that the electrical signal, we certainly think the electrical signal goes up the vagus nerve to the brainstem and results in some sort of kind of resetting of the brain. But really, exactly how that happens is still a bit of a mystery to us. But for some individuals, this can work really well. Again, this is not a holy grail. There are some people that respond well and some people that have only minimal response to vagus nerve stimulation. But this is typically used in individuals that have failed at least 2 pharmacologic treatments for their seizures, and a non-pharmacologic treatment is indicated. And then a newer stimulation technique is responsive neurostimulation. In this case, the electrical leads are placed directly into the brain, as is the stimulator. And in this case, the the stimulator can actually recognize when an individual is having a seizure and send stimulation to the area where the electrodes are. Where the electrodes are placed is determined uh, by surgical planning, where things like prolonged EEGs or even implantation of electrodes have been performed to identify where within the brain seizures are most likely to come from. And so when a seizure occurs in that area, the stimulator recognizes that, sends an electrical signal to the area to try to quiet down the area. So in this case, again, this sort of responsive neurostimulation really works best, or for all intents and purposes, only works for individuals who have 1 or 2 foci, 1 or 2 locations within the brain from which most seizures emanate. Those individuals with more generalized seizures that occur all over the brain, all over at once, would not be such great candidates for this sort of responsive neurostimulation. And then there are neurosurgical treatments that are available for individuals with certain types of epilepsy. One is due to lesions in a region of the brain called the temporal lobe. This is a region that can relatively frequently become damaged, usually because of prolonged seizure activity, and then become a significant focus, a significant area from which seizures can occur. And so a neurosurgeon can go into this region and remove either the entire temporal lobe or remove part of the temporal lobe. And this can, in some cases, substantially decrease the frequency and severity of seizures. Again, this is done in in collaboration between epileptologists, neurologists, and neurosurgeons who identify candidates that they feel are very likely to respond well to this. You might think, that would be devastating to an individual to have a region of their brain removed, but it turns out individuals with damage to these regions where you're having frequent seizure occurrence, that region usually is not being used normally anymore. Those duties have been potentially transferred, at least in part, to other regions of the brain. So typically, individuals that have these sorts of neurosurgeries do quite well. Obviously, with any surgery, there's always a risk of some complications. And then a last type of neurosurgery that can be used in select individuals with certain types of seizures is something called the corpus callosotomy. This is usually used in individuals with generalized seizures, most commonly in individuals with atonic seizures. And what's done here is that a bit of the central nervous system called the corpus callosum, this is basically a highway between the left and right hemispheres so that communication can occur between these two hemispheres, is severed, at least partially and sometimes completely. The idea here is that even though a person may be manifesting with generalized seizures, the seizures begin in either the left or right lobe, but they very quickly cross to the other side of the brain through the corpus callosum. So if that corpus callosum is severed, then the seizure cannot generalize as quickly as before the surgery, and the effect of the seizure is not as severe. For some individuals, this can really be life-altering. And again, typically used for generalized seizures, and most typically for those atonic seizures, which again are very brief but can be quite devastating because of the complete loss of tone. And then finally, a last non-pharmacologic treatment is the ketogenic diet. And many of you may have heard of the ketogenic diet. This is basically sort of akin to something called the Atkins diet, which individuals use for weight loss. This basically changes the energy source for the brain. So instead of having lots of carbohydrates, lots of glucose going to the brain to fuel, to provide energy, instead we have a large amount of fat that's consumed, and digestive products of the fat, specifically ketone bodies, are used to fuel the brain. And then you have a small amount of carbohydrates, and then usual amount of protein. This, again, is something that is used for individuals with really medication-resistant seizures, with intractable epilepsy. And depending on the individual, this can be something that's relatively easy to maintain, or relatively difficult. If an individual or a child, for example, with Phelan McDermid syndrome, takes all of their food by mouth, they have to dramatically change the types of foods they eat. Lots of things with high fat, often things like meat with a big pad of butter on top of it, and no or very minimal carbohydrates. So it can be difficult to keep a child on this. Obviously, if a child is, for example, G-tube dependent, then everything can go through the G-tube, and then it becomes relatively easy to maintain a ketogenic diet. This should definitely be done only under the observation of a neurologist or a epileptologist, ideally, and also with the help of a dietitian. There is some danger, minimal with monitoring, but some danger with this diet in terms of developing something called acidosis, which can decrease alertness, and can actually cause hospitalization if the diet is not monitored closely. So this is definitely something not to think, oh, it's just a diet, I'll just try it at home. Definitely should be done under the supervision of medical care. Okay, so we're going to move on now and talk about some of the life-threatening complications that can be associated with epilepsy. So the first one I'm going to talk about is something called status epilepticus. So this is a state of either continuing or recurrent seizures in which cognitive recovery is incomplete. So either a child is seizing nonstop, or they have a seizure, a brief seizure, stops, never really regain consciousness, and then have another seizure and kind of go on and on like that. This is definitely a medical emergency. So if this happens, a child needs to be seen as soon as possible by a medical professional. By definition, we say the status epilepticus occurs when a seizure occurs, lasts for longer than 30 minutes, but really in practice, any seizure longer than 5 minutes, that becomes a medical emergency, needs to be treated as status epilepticus and be seen in a hospital for management. So what is concerning about status epilepticus? Well, there have been a few studies that have looked at the impact of status epilepticus on what we call morbidity and mortality. That is on basically injury or death associated with it. And what we see is that when a seizure lasts longer than an hour, the survival dramatically decreases in the month following that seizure. Whereas an individual who has a seizure that lasts less than an hour, there's really very little impact in survival. Now, this is certainly confounded by the cause of seizures that last more than an hour. Many times, these are sudden catastrophic events that occur to the brain. Things like bleeding in the brain or like a stroke in the brain can cause a prolonged seizure. Nevertheless, we always do our best as neurologists to try to limit the length of a seizure, certainly less than an hour. And we do this usually by IV or intramuscular medications that are administered in a hospital setting. And then looking more in depth at the mortality associated with prolonged seizures, this is most manifest in individuals that are older than 60, 70, 80 years of age. And again, this is in part because of the prolonged seizure, certainly, but also often because of the underlying cause of that prolonged seizure. Again, things like bleeding in the brain or stroke or tumor that independent of the seizure event would um, potentially be catastrophic for that individual. Nevertheless, you see that there is some mortality associated with status epilepticus in children, and certainly any child that has a seizure longer than 5 minutes, we very aggressively try to stop that seizure. Okay, a second, but certainly more rare event is sudden unexpected death in epilepsy, or SUDEP. This can occur within minutes or hours following a witness seizure. We really don't understand the cause or etiology of SUDEP that well. We don't know if often it occurs immediately following an unwitnessed seizure, or if really having a seizure a few hours before just predisposes predisposes some individuals to death. It seems to be most common in adolescents and young adults. And it certainly seems to be most common in individuals with generalized seizures versus those partial onset seizures emanating from just one part of the brain. Again, the cause is not really clear. Some of the hypotheses include things like autonomic dysfunction. The autonomic nervous system controls things like heart rate and breathing rate. And dysfunction of that could potentially lead to cardiopulmonary arrest, which might be the precipitating factor of death. Apnea, or again, cessation of breathing could be one of the causes, or cardiac arrhythmias in some cases seem to certainly be a cause of SUDEP. Again, this just shows some of the data regarding in which individuals SUDEP can occur. And what you see is basically, if you look kind of over here, that it seems to be most common in individuals less than, let's say, about 45 years of age, and exceedingly rare in older individuals. Okay, so now let's turn to Phelan McDermid syndrome, and what's the literature regarding seizures in Phelan McDermid syndrome. So I'll start with the older literature. basically prior to about 5 years ago or so. There were 12 retrospective studies describing the prevalence of seizures in individuals with Phelan McDermid syndrome. They were kind of all over the place in terms of the prevalence, anywhere between 14 and 70%. This in large part reflects that the size of some of these studies were quite small, just really a handful of individuals. Now there's one prospective study that has, it's part of the natural history study that many of you are probably involved with, where individuals with Phelan McDermid syndrome have been enrolled in this research study. And then after enrollment and kind of going through the process of the study, it was determined that the prevalence in that group of, that population of individuals with Phelan McDermid syndrome was around 40%. At kind of again circa 5 years ago, detailed description of seizure types, frequency, medication use, and EEG abnormalities. We're only in 2 studies and relatively small studies. And then from the natural history study, we now have some data regarding longitudinal analysis of EEG changes and specifically of prolonged EEGs, and I'll go through that in a bit. So really the first study describing in some detail seizures and EEG patterns in Phelan McDermid syndrome was this one from an Italian group who evaluated seizures in 6 individuals with deletion of 22q13. These included individuals with deletions of various sizes, from relatively small, really primarily just involving SHANK3, to relatively large deletions encompassing a large number of genes. And then one individual who had a relatively large deletion but did not include SHANK3, which again, SHANK3 is thought to be the causative gene of most of the neurologic symptoms of Phelan McDermid syndrome. So in this study, again, they had a total of 6 subjects that were recruited. 3 of those had a diagnosis of epilepsy. But in addition to this being a relatively small study, there were other confounders of this. One was that one subject with epilepsy had that deletion non-encompassing SHANK3. Another had a history of meningitis and the neonatal period, which by itself can certainly lead to a diagnosis of epilepsy. So in that individual, it's certainly unclear if their seizures were a result of their genetic diagnosis. In that report, all were said to have a relatively benign course, and I'll certainly in a minute go into kind of our data, which suggests that's definitely not always not always true. And then EEG abnormalities that they identified were primarily this multifocal spike and wave, which is basically a indication of the potential for seizures, but not actually a seizure itself. Another study published in 2014 looked at epilepsy, and they broke down epilepsy based on age. And what they found was that individuals with Phelan McDermid syndrome tend to have an increased risk of seizures as they age, such that children less than 5 years of age, there's only, in this study, there was only about a 10%, only about 10% of those individuals had a diagnosis of epilepsy, whereas the adults with epilepsy had greater than 50% of those had a history of had a diagnosis of epilepsy. So overall, they found around 25% or so of individuals with Phelan McDermid syndrome had a diagnosis of epilepsy. Okay, so now I'm going to describe our experience at Texas Children's Hospital with regard to epilepsy and Phelan McDermid syndrome. So at the time, I had enrolled about 24, 25 individuals with Phelan McDermid syndrome, and we basically performed an in-depth, some deep phenotyping based on their medical record. And what we found was that among our 24 individuals with Phelan McDermid syndrome, 11 had a history of at least one seizure during their lifetime, which is about 46%. One thing to keep in mind, a couple of things to keep in mind about that number. First of all, relatively small number of individuals. And then second of all, I happen to be a neurologist interested in seizures and rare neurogenetic disorders, so I might tend to recruit individuals with epilepsy to my clinic. So it might be a little bit on the high side. And when we combined our data with all of the combined data from previously published studies, we found a prevalence of about 32%. The mean age of onset when the first seizure occurred was about 5 years of age, but there's really quite a wide spectrum of when seizures began, from 14 months to 14 years of age. And the seizure burden was also quite wide. Again, over half of the kids that even I saw did not have a history of any seizures. We also had some individuals in that 46% who had basically a history of one seizure in their life, to a couple of individuals who had a really large seizure burden. The most common seizure type that we saw was something called atypical absence. So I showed you an example of an absence seizure at the beginning. An atypical absence, there's kind of a strict definition related to the EEG findings in these individuals. But more clinically, these seizures might be not quite as common, or the seizure burden might not be quite as high as for typical childhood absence epilepsy. But each individual seizure might last a bit longer than you expect to see. Not that 10 to 15 seconds, but longer, like 30 to 60 seconds. But we saw a wide variety of different types of seizures in these individuals. Generalized tonic-clonic seizures, again, these grand mal type seizures that you typically think of when you think of epilepsy. Again, atonic seizures, myoclonic seizures, and focal seizures were all present. About 20% of the kids in my group had a history of status epilepticus at some point in their life. And then we had a couple of individuals that had a clinical diagnosis of something called Lennox-Gastaut syndrome. This is not a genetic diagnosis, but it's a diagnosis based on a combination of the types of seizures an individual has, as well as a certain EEG finding. The reason this is important is Lennox-Gastaut syndrome indicates quite a severe epilepsy that's difficult to control with medication. And then looking at EEGs, or those brainwave tests, in our children with Phelan McDermid syndrome, we found that EEG abnormalities were quite high. 67% of our kids had some sort of EEG abnormality. So thinking back to the percentage of kids with a diagnosis of epilepsy, this clearly means that many children without a history of any seizures have EEG abnormalities. The most common finding was slowing or absence of the occipital dominant rhythm. This is an electrical recording sign that we see in individuals, in all individuals. And the frequency of this rhythm varies with age. So we can predict, based on an individual's age, what we should see in terms of the occipital dominant rhythm. And basically what we found is that in almost half of children with Phelan McDermid syndrome, that electrical activity was either slow or absent. This tends not to be associated with seizures necessarily, but more with cognitive dysfunction. We also saw focal spike and slow wave discharges. These are regions, focal regions of irritability or predisposition to seizures in the brain. And again, close to 40% of children with Phelan McDermid syndrome had these signs. And then we also saw, instead of the focal, localized regions of irritability, in about 20% of kids, we saw discharges that emanated from all of the brain all at once. And again, this just indicates a predisposition to seizures. It's not a seizure event itself. And again, we saw abnormal EEGs in individuals without a history of seizures. In general, in our group of patients, individuals with multiple seizure types, basically more intractable epilepsy, were more likely to have a slow occipital dominant rhythm than those with either no seizures or relatively low seizure burden. So I thought I would just show you an example of an EEG, which is shown here. Basically, it looks like a bunch of squiggly lines, right? If we look at the first couple of seconds here, this is a typical EEG from the awake individual. You can see very small but very frequent squiggly line here. That's what we expect to see. Then beginning here in this third second, you see this huge wave of activity that occurs over the next 2 to 3 seconds. And then we go back to this low amplitude, the small high frequency activity. So this big wave, this is the spike and wave complex that I mentioned earlier. In this case, we have sort of a generalized appearance of a spike and wave complex is occurring over about 3 seconds. Again, this was an individual who clinically did not change during this period. So this was not a seizure, but this is just an indication of potential for seizure. So we also looked at MRIs in our kids with Phelan McDermid syndrome to see if there's anything in the MRI, anything in the structure of the brain that could give us a clue that an individual with Phelan McDermid syndrome is likely to have a seizure. And it turns out there really was not. MRIs from kids with Phelan McDermid syndrome tend to be relatively normal. There are some findings that we see somewhat commonly. Among these involves the structure I described earlier, the corpus callosum. This is the highway between the left and right hemisphere. It can be relatively thin compared to what we see in neurotypical individuals. Again, this is not correlated with seizures in this population or really within any population. And we relatively frequently see this in individuals with intellectual disability from all causes. And then in a region called the deep white matter, this is basically a region where neurologic signals are sent from the cortex. These are the principal brain cells. These include the principal brain cells. And those communicate with other regions of the brain through this deep white matter. There we can see some very subtle abnormalities, something called hypomyelination, which means basically that the wires, if you think of the neurons as producing wires to send those electrical signals to other regions of the brain, the myelination just isn't quite as thick as we would normally expect. Again, this is something we see really in many individuals with intellectual disability from all causes, and not something specifically associated with epilepsy. Okay, and then in terms of treatment, so our patients had been described 16 different anticonvulsants. None of them clearly had superiority or were less efficacious than others in the Phelan McDermid syndrome population. We had a couple of patients who had a vagus nerve stimulator placed, and there was some improvement in seizure burden. Somewhat like with a new medication, many children who have a vagus nerve stimulator implanted will have dramatic improvement in their seizure burden immediately, but then sometimes that wanes with time, and that can happen, as I mentioned earlier, with a new medication as well. We had one child at the time that had a history of corpus callosotomy with some significant improvement in severity of their atonic seizures. And then I thought I'd end this by just mentioning that our Texas Children's Hospital is now partnered with Mount Sinai for a clinical trial specifically looking at Phelan McDermid syndrome, looking at individuals with Phelan McDermid syndrome who also have a diagnosis of epilepsy. This is a pharmacologic intervention that is infused through an IV. This is a phase 1 trial, meaning that in this preliminary trial, we're really looking mostly at safety, but of course, always looking to see if we see some signal of improvement in either seizure burden or in other things like EEG abnormalities or even behavioral abnormalities. This trial is ongoing, so if there's anyone on the call that's interested in participating in research, can certainly either contact myself or contact the Mount Sinai group if you're closer to them about participating in this study. All right, and then the last thing in terms of seizures and epilepsy I'm going to discuss is one paper describing the use of long-term EEGs in children with Phelan McDermid syndrome. This was part of the prospective epilepsy study, enrolled 16 participants, 43% with epilepsy, so similar to the prevalence that we saw in my population. That study reported that most individuals with Phelan McDermid syndrome had some sort of generalized slowing of that occipital dominant rhythm, although it did not give specific numbers. And then what they found, kind of the key point of this paper, was that when they did this sort of routine EEG, which is this 30 to 45 minute EEG, They found about 25% of individuals had some sort of epileptiform activity. Again, these were not recorded seizures, but just abnormalities that suggest a predisposition to seizures. In contrast, the same group then went on to record long EEGs, basically an EEG overnight or around 24 hours. They found that they could identify in 75% of a subset of the same population, they could identify these epileptiform abnormalities. And then in this study, no seizures were recorded during any of the EEGs. And then another finding that they had from the study was something called sleep accentuated epileptiform discharges. So one last EEG, so don't worry, this will be it. But basically on the left here, what you see again is a normal EEG from an individual that's awake. So you see this kind of densely squiggly line here. Over on the right, the same individual is now asleep. And what you see is basically that a lot of those squiggles are gone. It's a little bit lower frequency activity of the brain. And then suddenly, about 3 or 4 seconds into the study, you suddenly see these squiggly lines again that are really higher amplitude than what we see typically in an awake individual. So again, this is this epileptiform discharge that I've been talking about, this region of, this indication of brain irritability. And basically, they found, at least in some individuals with Phelan McDermid syndrome, this tendency to increase number of these discharges with sleep. So altogether, at the end of this, kind of in the conclusion of this study, that the authors suggested that a overnight EEG might be beneficial for children with Phelan McDermid syndrome. I'm a little bit more cautious about this. I definitely do not recommend an overnight EEG for every child with Phelan McDermid syndrome, especially not in those children who've never had a history of a seizure. But it's something that certainly can be useful for some children with Phelan McDermid syndrome. And really, I think it's up to individual neurologists to kind of make this decision. Again, so this just shows that with those routine EEGs that they saw epileptiform discharges in 6 out of 16 children, but then with the overnight EEG in 12 out of 16. And so really all of the work I've described so far is in, I guess what you might describe as classic Phelan McDermid syndrome. That is due to deletion of part of chromosome 22q13, usually involving SHANK3. But there, with the rise of whole exome sequencing technologies for clinical diagnosis, there are an increasing number of children and adults diagnosed with point mutations in the SHANK3 gene. So what about seizures in these individuals? So we participated in this study, also, again, spearheaded by Mount Sinai and Alex Kolivzon's group. And what we found was that from the literature, from one study, that about 12 out of 30 individuals with deletions of chromosome 22q13, again, what I'm sort of describing as classic Phelan McDermid syndrome, had a history of epilepsy. So again, about 40%. In our patients that we collected, that we identified with SHANK3 mutations, 5 out of 17 had a history of epilepsy, so about 30%. So there might be some slight decrease in the prevalence of seizures in children with point mutations in SHANK3 versus deletions of 22q13, although not a huge difference. So it certainly appears that even having a point mutation, only a point mutation in SHANK3 can strongly predispose you to strongly predispose an individual to having seizures. And just as a point of reference, in a general population, the prevalence of seizures is about 1% or so. Sorry, about 10%. About 10% of individuals will have a seizure some point in their life, and then epilepsy is about 1 to 2%. So again, this is clearly greater than what we see in the general population. And then finally, kind of ending this part of my talk, there are practice parameters that have been developed for Phelan McDermid syndrome. These are undergoing revision right now, and hopefully by sometime next year, we'll have some new guidelines for managing individuals with Phelan McDermid syndrome, but these are available on the Phelan McDermid syndrome website. Certainly for those individuals who take their child to a neurologist who's not so familiar with Phelan McDermid syndrome, these are a good starting point to share with them. And basically what's recommended from these is individuals with seizures, at least an outpatient EEG, and perhaps an overnight video EEG in some cases. Brain imaging is recommended. And then certainly occupational and physical therapy is strongly recommended. Okay, so now I'm going to change gears and talk about some work that we've done in the last year. So these will be relatively brief, and then we'll be able to then we'll wrap up. But I became interested in the impact of Phelan McDermid syndrome on health-related quality of life. So what is health-related quality of life? So it's a holistic measure of the impact of a chronic disorder on an individual's quality of life. And the way we measure this is basically through a questionnaire of around 30 or 40 questions, where we ask questions about 5 different domains related to an individual's quality of life. And these include school domains, the impact of a chronic disease on school functioning and school performance, the impact on physical functioning, the impact on emotional functioning, emotional well-being, the impact on psychosocial factors, and finally the impact on socialization. And combining all of these together, we get an idea of the impact of a chronic disease on health-related quality of life. So shown over here on the right is some of the data that we collected. So some of this is actually published data, for example, from healthy individuals and from individuals with type 1 and type 2 diabetes. So just to orient you, the instrument that we use to measure health-related quality of life was the PedsQL questionnaire. And with this, we get a score, a normalized score, such that 100 is perfect, meaning an individual has a perfect quality of life. What you can see is that for healthy individuals, their PedsQL score is usually somewhere in the 80s or 90s. And then with some chronic disorders that can occur in children, such as type 1 and type 2 diabetes, you see a slightly lower health-related quality of life in the 70s and 80s. And then when you get to intellectual disability and autism, you see a further reduction in health-related quality of life, now into the 60s and 70s. So this was all previously published data, and so we asked, what happens in Phelan McDermid syndrome? And what we found was that in Phelan McDermid syndrome, there was a significant reduction in the health-related quality of life, such that the average score was somewhere around 50 or so, with a range between 30s to 70s. And what was interesting to us is that this was actually significantly lower than what had previously been published for idiopathic intellectual disability, that is intellectual disability due to all causes, or autism, idiopathic autism due to all causes. We also looked at a couple of other monogenic disorders, neurodevelopmental disorders, Rett syndrome and autism or intellectual disability due to mutations in a gene called SYNGAP1. And what we found was that for all of these monogenic forms of monogenic neurodevelopmental disorders, their health-related quality of life was significantly lower than what was previously published for autism and intellectual disability. So we wanted to dive into this a bit more. We wanted to see what is it that's causing this reduction in quality of life. And what we found was that when we broke things down into the individual subdomains, physical domains, psychosocial, emotional, social, and school, that the scores that we saw for Phelan McDermid syndrome and also for Rett syndrome and SYNGAP1 related intellectual disability were similar to idiopathic autism, idiopathic intellectual disability for things like school performance, social performance, and emotional well-being, relatively similar scores. Where we saw a big discrepancy was in physical functioning. Children with Phelan McDermid syndrome had a significantly lower score for physical functioning compared to those with intellectual disability or autism due to all causes. And this was also true, maybe more so true, for Rett syndrome as well as for SYNGAP1 related intellectual disability. So this told me two things. First of all, that physical therapy or occupational therapy to improve physical functioning is really critical for children with Phelan McDermid syndrome, more so than we see for just for idiopathic autism or idiopathic intellectual disability. The second is that this holistic measure really, I think, is potentially a very useful endpoint for future clinical trials. And in particular, physical functioning, it seems to be something that's really impacted in kids with Phelan McDermid syndrome. And this is just a picture of my collaborator, Cornelia, who's a health economist and has helped us with this work. Okay, so finally, I'm going to end by talking about the impact of Phelan McDermid syndrome on sleep. So sleep in autism or intellectual disability is known to be significantly impacted. Individuals diagnosed with these disorders very frequently have sleep abnormalities. These can manifest in a number of ways. I just listed a few of them here. One very common thing that I hear is that kids with Phelan McDermid syndrome wake up a lot at night, sometimes go back to sleep, sometimes don't. They frequently have trouble going to sleep. They can have a relatively restless sleep, and then some kids just don't sleep very much, have a short duration of sleep. So we wanted to dive into this a little bit more. We wanted to, more in a quantitative way, evaluate sleep in children with Phelan McDermid syndrome, as well as for another neurodevelopmental disorder for which I see patients in clinic called SYNGAP1 intellectual disability. And in this case, we used another questionnaire called the Children's Sleep Habits Questionnaire. And again, this asks about 30 questions or so related to different types of sleep abnormalities that can occur. And what we found for Phelan McDermid syndrome, I think, was quite interesting. We found that on average, individuals with Phelan McDermid syndrome do appear to have a significantly increased risk of sleep abnormalities compared to healthy controls, which are shown here. When we looked at our total population, there was a strong trend for increased average score on this instrument. So in this case, just to orient you again, a higher score on this Children's Sleep Habits Questionnaire means worse sleep, means more sleep abnormalities. And so again, what we found was that kids with Phelan McDermid syndrome had worse sleep than healthy controls. We then broke down the population into those children less than 10 years of age and those children 10 years or older. And the reason we did this was basically to see if there was any impact of puberty on the presence of sleep abnormalities. And what we found for Phelan McDermid syndrome was that, in fact, at least in this population, that there was a significant reduction in sleep abnormalities in those children less than 10 years of age when compared to individuals 10 years of age and older. Now, that's not to say that children less than 10 years of age with Phelan McDermid syndrome do not have sleep problems. And we can clearly see there are individuals that have quite high scores with Phelan McDermid syndrome. But on average, the percentage of individuals with sleep abnormalities, or the overall score, I should say, was actually quite similar to healthy controls in this study. In contrast, again, individuals over 10 years of age, we saw really a strong effect on sleep abnormalities with Phelan McDermid syndrome. I will mention just at this point that there's another study that was published a couple years ago now, also looking at sleep abnormalities in Phelan McDermid syndrome, basically using the same instrument. Found somewhat similar results, although did not see quite the same impact of age on the prevalence of sleep abnormalities. So we dove into this a little bit deeper and asked, okay, what are the sleep abnormalities that are driving these increased scores? And we found a number of things seem to significantly impact the sleep scores. First are nighttime awakenings. So looking at the entire population of children we recruited with Phelan McDermid, or individuals we recruited with Phelan McDermid syndrome compared to healthy controls, significant increase in nighttime awakenings. And this was present, trended to being present in those individuals under 10 years of age, but strongly present in those individuals over 10 years of age. And then we also looked at sleep onset delay. This is basically how hard is it to get your child to go to sleep. And what we found was that for Phelan McDermid syndrome, there was a significant a significant impact of or significant increase in sleep onset delays compared to healthy controls. And again, at least in our population, seem to be driven mostly by those children or those individuals over 10 years of age. And then what was most surprising to me was the prevalence of parasomnias in children with Phelan McDermid syndrome. So parasomnias are things like restless leg syndrome, like sleepwalking, like night terrors, that can be manifestations of sleep abnormalities. And we saw a very strong increase in the prevalence of, sorry, we saw a very strong increase in the prevalence of parasomnias, both under 10 years of age and over 10 years of age in children with Phelan McDermid syndrome compared to our healthy controls. Okay, so that is what I wanted to share with you today. I want to end by thanking the Phelan McDermid Syndrome Foundation again very much for arranging this webinar. And then I can't thank the parents, the families of children with Phelan McDermid syndrome enough for participating both in our research and really all of the research that's going on around Phelan McDermid syndrome. I really, really believe that this is how we're going to move towards personalized therapies for Phelan McDermid syndrome. So your participation is really critical. And then just in terms of our clinical research, which is really what I talked about today, I have to thank Maria McCormack. She's my research coordinator. Many of you have probably received calls from her asking you if you want to participate. So I need to thank her, and then really everyone that I've collaborated with. So I'll end there, and I think Ronnie's back and can tell us what questions we have.
Great. Okay, we have quite a few. So I'm going, a couple of them, I think you came in really early, and I think you answered some, like the keto diet. Although one of the questions about the ketogenic diet was, is it is it indicated in specific types of seizures more than others?
So it's definitely indicated with increased severity of seizures, intractable epilepsy. In terms of types of seizures, it probably doesn't work quite as well with these partial onset seizures as it does with more generalized seizures. Actually, now that I say that, I'm not sure there's really data to support what I just said. I'd have to look back at the literature, but I would just say, just in my experience, that's the population that we tend to try it in. Ketogenic diet is one of those things. There's a lot that I'm really comfortable with doing. Ketogenic diet is not one of them. When I think someone needs a ketogenic diet, I send them to the specialist. When we basically have a couple of specialists at Texas Children's that do that. So that's the kind of the last thing I'll say about that. Again, is this is something that needs to be done under medical care.
Thank you. And then someone asked about a Mito cocktail. Is it good?
It's not bad. It won't hurt. So this is something that has come up quite a bit, actually, that I've heard quite a bit. Many children with Phelan McDermid syndrome are initially told, or their parents are told, that their child has some sort of mitochondrial disorder. I think the reason primarily that this is the case is because of some of the symptoms that kids with Phelan McDermid syndrome manifest. The sort of low tone, which I didn't really talk about, but many, many kids with Phelan McDermid syndrome, most probably, are floppy kids, floppy babies, floppy kids. And, many neurologists, rightfully so, when they see these kids, it pops into their mind, oh, this is a mitochondrial disorder, or perhaps it is. And I think many of them prescribe a Mito cocktail because it's pretty benign. It's basically a bunch of vitamins. So it's pretty benign. I've never seen a dramatic improvement myself in a child with Phelan McDermid syndrome that takes this. I have no indication that it really changes the clinical course. That being said, there's probably somebody on the call that would argue with me that it's not true. And you never know. I mean, any child can respond differently and to a particular treatment. So in general, it's not something I use.
Okay. We have someone going to the sleep issue. She says that her nonverbal daughter is 3 years old. There are no other medical conditions that she knows of other than PMS, but she cries for hours at night. And how does she start to figure out what is bothering her? Do you want to just take the medical piece of that, and then I can get back to the parent about some other resources if it's a behavioral issue?
Yeah. So I would say that anytime your child with Phelan McDermid syndrome is crying for an unknown reason, you definitely need to think about medical issues. And the one that I immediately ask about is, how are they doing with their GI system? How are they pooping is usually the big one. Or do they have a lot of reflux? Because when any individual lies down that has reflux, I do, so I recognize this, you tend to get more of that burning sensation, and a nonverbal child just can't tell you about that.
Right.
So I always go to those things first, to see if there's something there that we can work with. It could be a behavioral issue. I didn't get into this, there are definitely sleep aids that could potentially help. If you're going down that road, the first one I always try is melatonin to see if that works. It's
Right.
relatively benign.
Thank you. The next one is, if there is a suspicion that a child is having absent seizure activity, how soon do they need to get to a neurologist? And also, which is probably a general question for seizures in general, is when do we know that it's time to go to the ER?
Yeah, yeah. So pre-COVID, I would say, make your appointment for tomorrow. If you think there are seizures, I would probably still say that. So one thing I do want to point out is that in general, seizures do not cause brain damage. And that's something that is often concerned for parents, and rightfully
Sure.
so. But seizures, by and large, do not cause brain damage. Now, the only time that that's not the case is those really long seizures, that status epilepticus. That is a concern for brain damage. Kid is seizing nonstop for 30 minutes. That's a medical emergency, and that's an ER visit.
Right.
Your child suddenly has some staring spells, happens a few times a day. That's not an ER visit, especially not right now. I would not say that's an ER visit. But I would still make an appointment with a neurologist. Many neurologists are seeing kids by telemedicine. I'm doing that. But I think that's not something to delay for months and months and say, well, when COVID's over, I'll take care of that. That's something probably needs to be taken care of sooner.
Okay, thank you. This one's a little bit specific, but I think has some general application. This is an individual who was having abnormal EEGs, particularly at night, for a decade. Lately, they've been coming back normal, but the child has developed dystonia. They're taking baclofen and diazepam for the dystonia. And with a 24-hour EEG under sedation due to behavioral issues, there was no seizure activity, but there were a lot of movement disorders. So now the person's real question is, can seizures be so deep in the brain that they might not be detected by a regular EEG?
That's a great question. That's a question that many neurology residents wouldn't know the answer to. So, because that's a tough question. The short answer is yes, it's possible, but unlikely. And the reason I say that is when a seizure, so I talked about these foci, these basically localized regions of the brain that can initiate seizures. Those can be really deep and hard to identify on EEG. However, once something progresses to the point of a seizure, that is usually detectable by a routine EEG if it occurs while an EEG is in place, especially with an overnight EEG. So definitely those epileptiform discharges can be missed. I would say in general, seizures are not. There are exceptions, but they're pretty rare.
Okay, thank you. Another example, a 41-year-old woman. Seizures are managed fairly successfully with medication, coming maybe every 2 to 4 months. But the concern is that for days afterwards, there seems to be stiffness, dizziness, and mobility issues, like up to a week. And then she gets mobility back. Do you have any explanation about that, or how it might be treated?
Yeah, I mean, one question I would ask that, we won't get the answer today, but that's okay, is how long is the seizure? So certainly the longer the seizure, the more likely you are to have those sorts of side effects that follow the seizure event. So there's something called a Todd's phenomenon. And this is basically what you're describing, it sounds like, which is that following a seizure, part of the brain just doesn't function normally for a while.
Right.
Most commonly, this only lasts for a few hours, but I have seen it last longer than that. If this is something that your child does, then it's not something you really, I would have it evaluated once by a neurologist, but after that, really does not need to be reevaluated on a continuing basis. But what's causing it? It's probably because wherever the seizure occurred, that part of the brain just does not function correctly for a while. And that's
Mhm.
just some of those physical manifestations.
Thank you. This is back to sleep again. A parent who's reporting that they had tried a number of things due to increased hyperactivity at bedtime, and they have had success now with Surovexant. Belsomra is the brand name, and it is a dual orexin receptor antagonist, and it is very successful. And he's just wondering, is it possible that this is something that could be more broadly applied for PMS individuals to help them kind of shut their brain down?
I would love to know the answer to that. I don't know the answer to that. I want to know who this person is because I need to talk to them. This is something I've been thinking of for 2 years. I think this medication's been available for 2 to 3 years or so. And I've sort of wanted to prescribe it, but I've been a little bit shy about doing it, mostly because it's only currently approved by the FDA in adults. And I spoke to our sleep experts and they had no experience with it. So I just wasn't willing to be the first. So I'm really curious as to hear more about this. So
Okay, so if that parent would like to email me
yeah,
at ronni@pmsf.org, I'll be sure to connect you with Dr. Holder.
that'd be great.
Great. Another one, just a comment about sleep. A difficulty arose 2 years ago. They tried melatonin, but after a while it stopped being effective. They are now using cannabis with a 20-to-1 CBD to THC ratio in a 0.5 milliliter. Do you have any experience with this? So this is essentially medical marijuana, which obviously the ability to prescribe that differs from state to state.
Absolutely. I have no experience with it. I've definitely spoken with parents who've said that their child's received some benefit from this, but Texas is relatively strict on these sorts of things, so I have no experience.
Another one, that the child is having staring spells. They last 10 to 15 seconds, but during the spells, they're able to joke with her and she will laugh, but she continues to stare away and won't come back, make eye contact. Are those potentially an absent seizure?
Yeah, thank you for that question because I usually say something about these types of episodes and I forgot to this time. Chances are no, that's probably not a seizure. Staring spells can be caused by lots of different things or can be it can be caused by lots of different things, and just inattentiveness can cause it. So the classic sort of situation is your child is sitting on the couch, staring at the TV, staring out the window, and just kind of looks blank. But then when you try to get their attention, when you touch them on the face, they immediately look at you, not a seizure. Chances are staring spells where your child is still able to interact with you, very unlikely to be a seizure.
Great. Okay. And then this is a phenotype-genotype question. We'd all love those answers. Is there any relation to the size of the deletion in PMS related to seizures and their
Yeah, that's a great question. I've not seen anything in the literature yet specifically discussing that. In our population, which is relatively small, we haven't really seen a strong indication of that, meaning that with really large deletions, we can't say, oh, now it's 100% these kids have seizures. That's not the case. There might be some sort of mild genotype-phenotype correlation, but not as strong.
Okay. The other one, two look like people one who may need your slides. She said she just couldn't access the app because she doesn't have a phone or tablet. So I'll get back to her. That's about sleep issues. And then someone who asked about Epidiolex. So I can do the same thing there.
Okay.
And that was it. That were all of our questions for today. Thank you for answering them on the just straight up like that. That was great. I think we got a lot of extra additional information there. Your presentation, as always, was excellent, and we're always grateful to have you here, Jimmy. So now I'll just wrap up with the last little bits of housekeeping. If you would like to give us some feedback on this, which I do give to Dr. Holder, please go again into the app, to the speaker. And if you go to the session, actually to the session, and you go down below the description of the session, there's a little place where you can push to enter your evaluation. Please do that. That feedback is really important for us. And, you know, we're looking, of course, to being in Kissimmee again in August of July of 2021. So we hope to base some of the speakers on what information that we get back from the series. Again, I want to thank all of our sponsors because they've just done an amazing job. This is, again, our last session, so I want to thank everybody who attended. Many of you have asked about the sessions that you've missed. Today's session will be repeated tonight at 7 p.m. as a recorded session, but all of them will be grouped together and available on our YouTube channel. Hopefully we'll have a link to that in the next newsletter at the end of the month. So again, thank you all very much. And I look forward to hopefully seeing you all next summer in person for a very different kind of experience. Take care and have a great day.